Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. I'm your speaker, Dr. Joseph Sowka. My partner, Dr. Greg Caldwell, is conferencing in another country in a way different time zone, so we don't expect Greg to be here. But I've got the able assistance of our coordinator, Vanessa McDonald. Tonight's topic, clinical grand rounds and optic neuropathies. You got some nerve. And just to refamiliarize, if you don't know, I'm actually no longer in academia. I'm actually in a large medical surgical practice on the west coast of Florida, Sarasota and Venice, where I do a number of things, including the neuro-ophthalmology within our practice. These are my disclosures. I'm consulted with Bausch & Lomb, but all my disclosures have been mitigated. So this is a clinical grand rounds course. We're going to start off with a 28-year-old female who presents with intermittent blurred vision and visual grayouts, intermittent horizontal double vision, and chronic headache steadily worsening over 2 weeks. She claims white coat hypertension, has a shoulder injury for which she uses a muscle relaxant. Height and weight, she's 5'3", she's 220 pounds. Her acuity is normal in each eye. Pupils and motility are also normal at this visit. And we see bilaterally swollen optic nerves, a bit of a preservation of the cup, some juxtapapillary folds known as Patton's lines. And that will bring me to polling question number 1. What is the next medical test that this patient needs? Does she need an MRI, MRV, a CT, or an LP? And if you are interested in putting into the chat, where is this photo taken? What are we looking at in this photograph? So if you're interested, you can put that into the chat. What is the next medical test that this patient needs? Is it an MRI, an MRV, CT, or a lumbar puncture? Okay, Alaska. I have a couple of Alaskas there. I have an Iceland. Very good. Good thought. Good thought. That's actually the Mendenhall Glacier in Alaska. All right, we're getting a great response. I'm going to end the poll and share the results. The majority say MRI, but we have MRV, a smaller percentage. Lumbar puncture and CT scan, about the same. Excellent. Well, additionally, history, she's got dull ringing in her ears. Her blood pressure is modestly elevated at 142/100, not malignant hypertension levels by any means. Biomicroscopy remarkable. Intraocular pressure is 16. Visual field, she has a blind spot enlargement, nasal step defect in each eye. Serology is normal. She did undergo imaging. She had small ventricles. Otherwise, her brain was normal. Lumbar puncture, opening pressure 510. It should be about 290, no more than that. All CSF studies are normal. She was diagnosed with pseudotumor cerebri. But specifically, she has papilledema. That's disc edema from increased intracranial pressure. It is bilateral disc edema generally, and I've only seen one case of unilaterality in my entire career. It, like glaucoma, affects the superior and inferior aspects of the disc first. There will eventually be obliteration of the cup in severe stages, but initially the cup is preserved. Hemorrhages are very common. There's no spontaneous venous pulsation. That is obliterated by the increased CSF pressure that is being shunted down the common sheath. And these Patton's folds will emanate from the nerve, particularly temporally, and that represents advancing and regressing retinal edema. And there's a highly variable visual field defect. They start with enlarged blind spots early. They end up with glaucoma-like defects, arcuate and nasal steps, and in the end stage, it's a very constricted visual field. There is no afferent defect typically because of the symmetry in the condition, and acuity traditionally is typically pretty well normal. Visual symptoms include transient visual obscurations, not a blackout, not TIA, but a visual grayouts happening 20 or more times per day. And an intermittent horizontal double vision that can be from a unilateral or bilateral sixth nerve palsy. Headache is common, nausea and vomiting can be occurring as well. Dizziness often occurs, as does spontaneous pulsatile tinnitus. Now, types of papilledema. We have acute, we have chronic, and we have atrophic. Acute, as we see in the lower left, hemorrhages, exudation, very hyperemic, a lot of nerve fiber layer edema. That tells me what I see in the lower left. That is acute. That is a new onset condition. Chronic, as we see in the middle, there's minimal hemorrhage, minimal exudate. Collateral vessels may be forming, but it is generally a drier type of optic nerve. And atrophic on the lower right, this happens if the disc edema is chronic. The patient ends up with disc pallor. The swelling dissipates because dead things don't swell. And this is an eye that's actually losing all of its vision. And the disc edema is from exoplasmic stasis. This is a regurgitation of metabolic byproducts accumulated at the level of the optic nerve, because in papilledema, the cerebral edema is being transmitted along the common meningeal sheaths of the brain, the optic nerve, producing really an engorged, swollen optic nerve. Now, associated with intracranial abnormalities, we can have increased brain volume from a mass lesion that we see in the lower left. Maybe increased blood volume from intracranial hemorrhage, as we see in the middle, or increased CSF volume from the hydrocephalic state. Now, you don't need a huge mass causing midline shift to give you papilledema. And I also want to emphasize, the last several cases of intracranial masses that I've seen in practice did not have papilledema. But a small tumor that blocks cerebral spinal fluid flow between ventricles can lead to this hydrocephalic state. And these are all things that we're looking for when the patient gets imaged. Now, it's important to rule out the swollen disc masqueraders. Ultrasound can be helpful. Other techniques, OCT can be very helpful looking at these patients. Fundus autofluorescence may help identify superficial disc drusen. But acute papilledema is an urgency because we need to get neuroimaging to rule out an intracranial mass. Now, if that imaging is normal, a lumbar puncture is going to be done to measure cerebral spinal fluid pressure. We also there'll be an analysis to exclude meningitis and other processes. Now, when we talk about neuroimaging, these patients need both an MRI and an MRV, contrast-enhanced MRI, and a magnetic resonance venography to look for transverse sinus thrombosis. That will give increased intracranial pressure because fluid is not flowing properly. Now, atrophic papilledema, significant vision and field loss, is also urgent because these are patients that are going blind and they have to be addressed almost immediately. And any papilledema accompanied by any neurologic abnormalities, fever, stiff neck could indicate something neurologically very sinister, an intracranial infection, or a bleed that requires immediate medical attention. So if you have a patient who has what looks to be a chronic situation, they are not atrophic and there's minimal vision loss, it is not necessarily a patient that needs to go to the emergency room. But acute papilledema that has not compensated, or if there's any other neurologic evidence of infection, these are people that need to be admitted or addressed urgently. Now, I want to take a moment and just discuss this terminology. Pseudotumor cerebri versus IIH, or idiopathic intracranial hypertension. Now, I think a lot of people are under the impression that IIH is a newer term, a better term, a more appropriate term to use, and pseudotumor is an old term and should be not used. It's not actually true. Pseudotumor just means increased intracranial pressure, but there's no mass lesion. But there are many causative agents that have been identified. Tetracycline use, minocycline use, vitamin A, oral contraceptives. There are a number of exogenous agents that can cause this to occur. Venous sinus thrombosis. These are all things that can cause increased intracranial pressure, but there is no mass lesion. In that situation, if there is an exogenous reason, we call that a secondary pseudotumor. Now, IIH, idiopathic intracranial hypertension, is increased intracranial pressure, but there's no identifiable cause. There's no vitamin A use. There's no contraceptive use. There's no sinus thrombosis. There's no tetracycline use. These are the younger obese females who are at risk. We call that primary pseudotumor. So really, pseudotumor is the best term to use. It's either primary pseudotumor or it's secondary to pseudotumor. And it all comes from poor CSF drainage. The arachnoid villi just do not process the CSF properly. Now, making the diagnosis of pseudotumor, we need signs and symptoms consistent with increased intracranial pressure, and there has to be disc edema, and it could be subtle. They also have to have a normal neurologic exam. The only thing they're really allowed to have are cranial 6 abnormalities, because as the intracranial pressure elevates, the brainstem herniates down to foramen magnum. It stretches the 6th nerve across the clivus. We can get a unilateral or bilateral 6th nerve palsy. Neuroimaging must be normal, no hydrocephalus, no mass, no structural lesion, no thrombosis. CSS has to be normal, no fungus, no bacteria, no white cells, no red cells. And the LP has to be elevated. Now, here I have, in adults, we've always considered 250 and above. Well, a study really just came out that actually looked at the lumbar puncture opening pressure of a number of patients without, not with papilledema or pseudotumor. These people were just undergoing LP for other causes. And they found that normal actually ranged up to about 290. So probably we have to change this to about a 300 millimeter. Now, it is getting harder to get lumbar punctures done. However, neuroimaging is pretty sophisticated, and if there are certain things present, lumbar puncture can actually be deferred. First, MRI and MRV have to show no abnormalities, and they have to have these characteristic findings of a flattened globe. We can actually see here, there's dilatation of the anterior optic nerve sheath, and the globes are flattened. That's not a normal picture. Globe flattening and an empty cella turcica. Now, in the cella turcica is the pituitary gland. It is a gelatinous structure that is very malleable. The increased cerebrospinal fluid pressure will actually squash that gland down, giving it a pseudo empty appearance. So a pseudo-empty cella turcica, a globe flattening, these are all things consistent with the pseudotumor cerebri syndrome. If this is present and clear on imaging, lumbar puncture is likely going to be deferred if the patient is of a typical profile and there's no evidence of an acute infection. Now, manage these patients. If there's no visual loss, they're managed with symptomatic headache therapy, usually with their primary care physician. Acetazolamide, 500 milligrams 3 times a day, up to a gram 3 times a day. That's a lot of medicine, and it is a kind of a sickening medicine. So it's very, very tough to tolerate. Weight reduction is really the primary treatment for this, and the nauseating factors and the adverse effects of acetazolamide is actually an impetus for patients to try to lose weight. If they have mild visual loss, acetazolamide can be used, but also other diuretics as furosemide, topiramate, and zonisamide can all be used. Topiramate, Topamax, is actually an interesting medicine in that it has weak carbonic anhydrase inhibitor properties. It is also for symptomatic headache relief, and it helps with weight loss. So topiramate, if that medicine can be tolerated, is actually a fairly good medicine for these patients to use. And of course, weight reduction. So if they have no or mild visual loss, the prognosis overall is excellent. With 6 to 9 months of therapy, including weight loss, there's a very good chance that they're going to resolve. And these are patients, once they have resolved, frankly, you're not going to see any evidence of anything wrong when they are in a quiescent period. It's when they have chronicity and they develop atrophy. Now, what is very important is we need to be involved by doing follow-up visual fields, follow-up photographs, follow-up OCTs. Because when these patients get downstream to a neurologist, an internist, none of these things are ever going to be done. And we need to be staying involved, checking these patients on a periodic basis to make sure that the therapy is actually effective. Now, treating the primary problem, they need about a 10% weight loss. I've seen as low as 5 to 7%. Generally speaking, about 10% is what's going to help the patient the most. And when I start having these conversations, I explain, I have to ask, how much do you weigh? We need to know this. And a 200-pound woman has to lose 20 pounds, and that's not easy. And that sometimes will require the assistance of a primary care physician, a registered dietitian. They may need some help. And keeping the weight down will prevent the recurrence. Now, here's an interesting patient, young woman. Her BMI is not really all that high, but what we can see is this chronic bilateral disc edema in this young woman. Visual fields, we have an enlarged blind spot, and we look at on the serous OCT, we have what is called the Patriot sign, where the juxtapapillary thickness is so off the map, it's red, white, and blue, kind of like our flag. We call that the Patriot sign. Here's a 33-year-old female complained of horizontal double vision, and indeed she did have a mild 6th nerve palsy on one side. She also complained of headache and transient visual obscurations or grayouts about 20 times per day. Denied oral contraceptives, no tetracyclines, no vitamin A use. And she had offered, before any diagnosis had been made, she offered that she had lost about 10 pounds recently and noted that her headaches had improved. And that's what I've usually seen. Patients that I have these discussions with, once they lose a few pounds, they start feeling better. Conversely, when I have patients who are coming in with it and I'm making a new diagnosis, their headache is the precipitating reason that they come in, and they've gained weight. Their headaches have gotten worse. Well, she's got normal blood pressure, 5'5", very relatively modest BMI, not obese by any means. And this is what we see. She has bilateral chronic, what looks to be disc edema. We see a very, very thick juxtapapillary nerve fiber layer on OCT. We have a little bit of an arcuate defect in the right eye and a large blind spot in each eye. He underwent the requisite imaging and serology. And ultimately, she was diagnosed with pseudotumor. Now, over a period of time, she began a process of weight reduction and was using acetazolamide. Now, about 3 months later, we bring the patient back for follow-up, and what do we see here? Okay, as we go from here to here, we can photographically see there is reduction in disc edema. In the right eye and the left eye, there is reduction in disc edema. And we can see that the congestion and deficit in the visual field in the right eye seems to have improved. Now, this is why we need to be involved. First off, if I were to look at the patient at this visit and just look at them with nothing to compare it to, all I can say is the patient has disc edema. 3 months later, if I look at this eye, I can say the patient has disc edema. I don't know if it's improved or not unless I have photographic comparison. So OCT, fields, photos, very important. Because very easily I can turn these arrows around and maybe the patient goes from here to here and from here to here. Now we need to talk to the physicians who are involved in managing, saying the therapy is not working, the patient's getting worse. They don't know that, only we're going to know that. So that's why we need to be involved. Now, severe progressive loss of vision, we need optic nerve sheath decompression, where they can actually cut open the sheaths so the CSF can drain away to other compartments. To me, that's just loosening your belt buckle after Thanksgiving dinner. Give yourself a little more room, but you're still overstuffed. High-dose steroids and acetazolamide can be used. And many of these patients will need a CSF diversion procedure, such as a lumboperitoneal shunt to drain it to another body cavity. These are people who have failed on sheath decompression or won't do it, or have intractable headache, or are losing their vision. So this pulls me to polling question number 2. And make this launched. When encountering florid bilateral disc edema in a 39-year-old obese female, what is the next immediate step? Prescribe Diamox and recommend weight loss, immediately check blood pressure, immediately send to the ER, immediately perform OCT, and if you're so inclined to know, where are we? Where's this picture from? Somebody asks, how often should I see these patients? After diagnosis, 1 month, and every 3 months, about for the first year, then every 6 months. Have you ever seen preservation of SVP and PTC? I have not. You better rule out Chiari malformation MRI before doing the lumbar puncture. That goes without saying. Yes. No, it's not Notre Dame. Now, I am going to launch the handout again while you are. All right, very good. So people are rolling in nicely. I hear Switzerland, I hear Rome, Krakow, Notre Dame. That is actually the Tyne Church in Prague. One of the most impressive edifices I've ever seen. Very, very beautiful. So that is Prague, Czech Republic. All right, I'm going to end the poll. I'm going to share the results. Most everybody did check what I think is probably the first thing you should do is check the blood pressure. Any good neuroophthalmologist will tell you bilateral disc edema, you have to worry about malignant hypertension. Send to the ER immediately if you're willing to help and give them guidance. OCT can be very helpful, give you some information, photos, fields. The thing I want to stay away from is making a presumption of what they have and prescribing Diamox and weight loss without actually doing the appropriate testing. So remember, not all elevated discs are swollen, not all swollen discs are edematous, not all edematous discs are papilledema. True papilledema is an urgency. We have to treat it as such and look for a cause. And there are other conditions that can present with papilledema, including intracranial mass lesion, hydrocephalus, venous sinus thrombosis, and pseudotumor. And remember, it is a diagnosis of exclusion. We have to work through these cases. Now, that's a lot of stuff to remember. So I'm going to give you my ode to a swollen disc. When you think the disc is swollen, the vessels north and south will appear swollen. Not all elevated nerves are edematous, just like not all snakes are venomous. Your thought should go to papilledema, but infection, inflammation should still be in your schema. MRI, MRV, and LP are all soon to be. Remember, pseudotumor is a diagnosis of exclusion. Female infirm does not make it a foregone conclusion. Brain tumors can exist when the profile is classic. Do the evaluation so they don't end in a casket. If you can remember that, that's all about all you're going to need. So, which is better, one or two? Better one, better two. Better one, better two. Can you see it again? Here is a distinguished older gentleman and a distinguished middle-aged gentleman who both have ostensibly the same diagnosis. Now, what I wanted to point out is nothing on this slide should be interpreted that either Christopher Plummer or George Clooney were ever my patients. I am not saying that, but I'm not saying that either. 48-year-old male has a painless loss of visual field. He noticed when he woke up, he's still got 20/20 vision in each eye, but a new onset inferior arcuate scotoma. And what we see is a hyperemic swollen optic nerve and a disc at risk in the fellow eye, so glial tissue, small crowded nerve. And he has a non-arteritic anterior ischemic optic neuropathy. Compare and contrast that with a 74-year-old male who presents with the worst headache of his life. He goes to an emergency facility associated with a VA hospital. Here he sees a physician assistant, an emergency department physician, a cardiologist, a nurse practitioner, and ultimately 3 optometrists, all over a 3-week period, not the same visit. Now, when we look at the various visits and his history, he complained at various times of eye ache, jaw pain, scalp pain, facial pain, somnolence, to the point where he fell asleep while eating his food, malaise, and jaw claudication. At the very first visit, a physician assistant diagnosed him with temporomandibular joint dysfunction, even though he could open his mouth all the way. The ED physician signed off, didn't really examine him, treated him with an NSAID. Patient comes back a little while later, feeling still very poorly. They find a tick on him, and he is in a Lyme endemic area. So now he's diagnosed with Lyme disease and put on an antibiotic. Now, at various times, it was written in his chart, vasculitis such as temporal arteritis, highly unlikely. Somebody actually wrote not GCA. However, a SED rate and C-reactive protein were ordered. They came back elevated, but the results were never reviewed. Ultimately, an optometrist made the diagnosis in the absence or in the face of contradictory findings, actually got the patient oral steroids. Unfortunately, it was too late. The patient went bilaterally blind the next day. So that brings me to polling question number 3. A 60-year-old patient with headache presents with a pale, swollen optic nerve. What is the best referral? Neuro-ophthalmologist, possible ER, internist, or retinal specialist? And if you're so inclined, tell me where we are. And if you're so inclined, what is the name of this building? It is very famous. Andrea got it right off. the Chateau Frontenac in Quebec City, Canada. Again, one of the most impressive edifices I've ever seen. Six-year-old patient, headaches, pale, swollen optic nerve, best referral, neuro-ophthalmologist, hospital ER, internist, retinal specialist. Give just a few more moments for people to weigh in, but I think great responses from everybody. You're all doing terrific. I'm going to end the poll and share the results. Most people say a neuro-ophthalmologist. Some people say next to hospital ER, an internist or a retinal specialist. And I guess we could probably qualify these. A neuro-ophthalmologist, if the patient can be seen immediately. A hospital ER, if you're willing to help them. And an internist or retinal specialist, if they can be seen immediately. So they can all be very good options with certain qualifications. So anterior ischemic optic neuropathy is a hypoperfusion of the posterior ciliary artery circulation, the anterior optic nerve head. It can be arteritic or non-arteritic. Now, in the non-arteritic forms, certain mechanical factors such as arteriosclerotic disease, atherosclerotic disease will contribute, whereas in the arteritic form, an autoimmune vasculitis is the underlying cause. It is a unilateral presentation with a high incidence of subsequent contralateral involvement, especially if it's arteritic anterior ischemic optic neuropathy. In these patients, there is bilaterality in 65% of patients at an average time of 10 days. When these patients come in, the clock has begun ticking. Now, in non-arteritic anterior ischemic optic neuropathy, bilaterality can occur, but occurs on the average of 36 months. It is not rapidly sequential. And at 5 years, only 15% of patients with a non-arteritic ischemic neuropathy in one eye will have developed it in the other eye. So bilaterality is going to be pointing you away from the non-arteritic version to the arteritic version. If we want to look at the type of optic neuropathy, arteritic has a pale, swollen optic nerve, whereas in non-arteritic, it is a hyperemic swollen nerve. There's dilatation of the disc capillaries and telangiectasias, and the optic nerve is trying to reperfuse the infarcted part of the this optic nerve. Typically, we're going to have an issue infarcting the superior optic nerve, giving us a 6-to-1 inferior arcuate defect. We don't anatomically know why that happens, but 6-to-1, the defect will be inferior. So for non-arteritic risk factors, high blood pressure, diabetes, atherosclerotic disease, smoking, cataract surgery, small optic nerves, and it's not an altitudinal defect. It's often an arcuate defect, very similar to glaucoma. And we're looking at a hyperemic swollen nerve in a disc at risk. 98% of these patients have a 0.2 or less CD ratio, and the other 2% of the patients have been misdiagnosed. They can have progressive moderate vision loss over several days with potential recovery at 6 months of 3 or more lines of visual acuity. The earliest I've ever encountered is, I think, age 37. So this is in the late 30s, early 40s, and beyond. And it is painless. Very important, painless. Arteritic ischemic neuropathy is a pallid, swollen optic nerve. There can be retinal and choroidal infarction, isolated cotton wool spots, and pain of some sort: jaw pain, head pain, eye pain, shoulder pain, girdle pain. They usually have some sort of symptoms with a severe optic nerve dysfunction. Usually patients will be 2200 or worse or they can have good or decent acuity with a markedly constricted visual field. And again, if you can measure the visual field, it's going to be very similar. It is going to be an inferior arcuate defect. Now, giant cell arteritis and polymyalgia rheumatica are risk factors. I practice in a primarily Caucasian population and a very elderly population. A number of my patients have already been diagnosed with polymyalgia rheumatica, and we always have this conversation. When they do, I tell them, any new headache, let me know. Transient visual loss, transient double vision, let me know immediately. And giant cell arteritis and polymyalgia rheumatica are probably in the same spectrum of disease process, just albeit at different ends of the spectrum. Whereas rheumatologists see patients with polymyalgia rheumatica with some muscle aches and a little bit of headache, and they treat them with relatively low dose of steroids. Whereas optometrists, neurologists, ophthalmologists, we're seeing giant cell arteritis where they have a more pronounced history and are treated with a much higher dosing of steroids. Typically, this happens in the 70s. Average age of onset is 72 or 73, depending what study you look at. It is not that common under the age of 60, but it does occur. The magic number is 50. 50 and above. At any point, if you were to pick up any current literature on arteritic ischemic optic neuropathy, giant cell arteritis, I can virtually guarantee you that the first sentence in that manuscript introduction is going to say something to the effect of an autoimmune vasculitis that affects patients over the age of 50. Somewhere in there, in the very first sentence, will be the phrase over the age of 50. So once you hit 50, this is always on the menu. And don't get angry at me because I'm saying 50 is considered elderly. Don't hate the player, hate the game. And we talked about the high risk of bilateral involvement. So making the diagnosis, we have to ask directly about the non-visual symptoms. Headache is present in over 90% of these patients and is almost diagnostic. Scalp tenderness, jaw claudication, and scalp tenderness does not have to be temporal. It could be occipital, can be at the crown, the top of the head. Jaw claudication. Don't ask the patient, do you have pain while chewing? They can misperceive this. It's like they're eating a tough steak or beef jerky. As they're chewing, the muscles of mastication become ischemic and the jaw gets tired. Ear pain, arthralgias, temporal pain, temporal tenderness, malaise, intermittent fevers, these are all things that we have to ask about. Of course, we can do the examination, and we're going to be looking for a number of things, such as disc swelling, evidence of choroidal or retinal infarct, and we're going to order some lab studies. The big ones that we want to have are erythrocyte sedimentation rate, C-reactive protein, and platelet count. ESR is lowered by statins and NSAIDs, so patients are on these medicines that can actually give a false negative. C-reactive protein, which actually is not as readily available in terms of results as the ESR, is not affected by statins or NSAIDs. And an elevated platelet count, we're always going to look for thrombocytosis. An elevated platelet count could be more diagnostic than an elevated SED rate, and a normal platelet count could be more helpful in ruling out giant cell arteritis than a normal SED rate. So these are all things that we have to look at, and we're also beginning to look at some liver function studies in this condition right now. But these are things that if you ever write down query giant cell arteritis, we're really obligated to get these tests immediately. And depending on the clinical presentation, we can either get them through an outside lab, or send them to the emergency room to have these done. But of course, we're now working with the ER physicians in those situations. So initial symptoms, headache, polymyalgia rheumatica. You can think chair, hair, stare, and fair. Chair, it hurt. It's tough for them to get out of recliner chairs. Hair, it hurts when they comb their hair. It's tough for them to walk up stairs. These are all the muscles that are involved in polymyalgia rheumatica. And I put in there fair because we always think that this is a Caucasian disease. And the question comes up, do patients of color get this disease? The answer is yes. The reason that we've always thought this was a Caucasian disease is because of a population study that was done many years ago that looked at the majority of a number of things, and the vast majority of patients with giant cell arteritis were Caucasian. The caveat is this study was done in Olmsted County, Minnesota, where most of the people were Caucasian. When we look at the same type of study in Baltimore, Maryland, it is much more represented. In fact, about 30% of the cases out of Baltimore actually were people of color. Visual symptoms without visual loss. Transient ischemic attacks or transient double vision that are not happening in the office. If they sound legitimate, we have to look at this seriously. Weakness, malaise, fatigue. Now, what do these things all have in common? They can all have a normal exam. I'm just going to go to the chat room real quick. Somebody else said Frontenac. Yes. How often do you see non-arteritic anterior ischemic optic neuropathy second to use of PDE5 inhibitors such as Viagra? The answer is I've never seen it. It happens. It's reported. There are about 53 cases reported of non-arteritic anterior ischemic optic neuropathy in patients who have using the erectile dysfunction medicines. But there's a risk, but it's a low risk of a low number. I myself have never seen it. Not to say it doesn't happen. I've not come across it. And we also have to consider that many patients who, Thomas said, practicing 37 years and seen one. Yeah, it's a low number of a low number. Now, we also have to consider a lot of times patients who are using these phosphodiesterase inhibitors, they also are male, they're older, they can have diabetes, they can have hypertension, they can have other reasons for impotence or erectile dysfunction, and that's also a contributor. So it's hard to ferret that out. So looking at the pain, head pain, if we look at the vascular distribution, we've got the temporal artery, but the temporal artery is just accessible and expendable. Nothing magical about it. Involvement in the temporal artery does not predicate involvement in the cilio-retinal circulation or the posterior ciliary circulation, vice versa. Facial artery, lingual artery, occipital artery, correct? So we can see here, we can have neck pain, we can have scalp pain, jaw pain. There's just a number of things that can be involved. So the pain can be temporal, occipital, it can be the crown of the head, in the ear, the jaw, scalp. It is not that diagnostic as to where it's not always right here. But one thing that I do whenever I mildly suspect the temporal arteritis, or if I don't have a high degree of suspicion, I will palpate their temporal arteries. And if I feel a pulse, that's actually a very good sign that they do not have this vasculitis going on. So I will always palpate the temporal arteries to see do I feel a pulse. And if I do, I feel better. So vision loss and ocular findings in giant cell ischemic neuropathies, about 5% of central retinal artery occlusions are caused not by embolon, but by this vasculitis. A posterior ischemic optic neuropathy, where you look in, they have devastating vision loss. They have a relative afferent pupillary defect, but a clean, normal-looking optic nerve is a posterior ischemic optic neuropathy in the elderly, and that is almost always giant cell arteritis. Transient ischemic attacks are often can be due to giant cell arteritis and transient diplopia. In fact, one of the last cases of temporal arteritis I've seen in my practice was a sixth nerve palsy caused by giant cell. And I come across temporal art. Well, first off, I probably have to order the serology and rule out temporal arteritis at least once or twice a week. I probably see a true case of ischemic optic neuropathy about once a month. So looking at making the diagnosis and treatment, I'm not going to go through everything. It has been questioned, do we really need to have the confirmatory biopsy? And the answer is, we probably should try to get confirmation that they have this disease. Because when the patient is being treated with steroids, and they're having adverse effects from the steroids, the internist who's treating the person is going to want to get him off of steroids. And if we have confirmatory information, they know they have the disease, we know they have the disease, the internist knows they have the disease. Now, temporal artery biopsies can have false negatives. Always read the report. I mean, I don't look at slides, but I look at the report. You know, a negative biopsy, read the report. It may say no giant cells. First off, 50% of cases will have no giant cells. They have other inflammatory cells. But it'll say no giant cells, no active arteritis. But if it says there's a focal interruption of the internal elastic lamina, that means it's a healed arteritis. They have the disease. Nowadays, we are doing more and more temporal artery ultrasounds. Easier to obtain if you trust the ultrasonographer. It is much less invasive. Now, where I am, we have a great vascular surgeon in Sarasota who does temporal artery ultrasounds for us. Can get them in same day or next day if I need to. And it is actually pretty accurate. There's a little bit higher false positive rate with a temporal artery ultrasound, but it does compare pretty favorably with a temporal artery biopsy. Also remember, with temporal artery biopsies, not all pathologists are created equal. I've seen negative biopsies become positive biopsies when somebody else reads the slides or redoes the sectioning. But in Europe, they've stopped doing biopsies. They're doing now all temporal artery ultrasounds. So that is what I typically do. Unless the patient is being admitted to a hospital and they have a protocol of biopsy at the hospital, I usually recommend go ahead and get ultrasounds. Now, treatment. They need steroids and they're going to need hydration. They're also going to need protection for diabetic issues. They're going to need gastric protection from the steroids, and they're going to need help sleeping because they become insomniacs. IV is really the way to go when vision loss is present. When there's vision loss, we're trying to save the other eye. IV steroids very effective in preventing second eye involvement, and occasionally actually does restore vision in the involved eye. But this is best done through an emergency room. If I know in my heart of hearts I'm dealing with an arteritic ischemic neuropathy, I will send the patient to the ER, but I send them with my orders, my recommendation, and my cell phone number. I also have something here I want you to all be aware of. Keep this little cheat sheet here. What is the dosing? It is 250 milligrams Solu-Medrol 4 times a day for 3 days, inpatient IV, followed by 60 to 80 milligrams of oral prednisone upon release until they can be seen by a rheumatologist. And why do I need to know this? Because I can guarantee what happens. I see about one of these a month. I will I get the patient from the ER, they go back to the ER, I send them to the ER. I know they have an arteritic ischemic neuropathy. In a couple hours, I'm going to get a call from the ER physician. They'll tell me, okay, the tests are, the numbers are elevated. What do I do now? And they'll ask, what dosing do I use? And I tell them you need a divided dose, 12 doses divided over 3 days, methylprednisolone, solumedrol, followed by oral steroids, 60 to 80 milligrams. Do you want me to help you get an ultrasound, or do you have a surgeon who can do a biopsy? Right? They usually, we talk through it and they say, thank you very much. And about half the cases, about 2 hours later, I'm going to get another phone call. And now it's the hospitalist who's going to admit the patient. And they ask me the same question. Okay, what do we do now? Weight dosing, how much do we use? How do I do it? How long do I do it? And what do I do on release? If you can tell them that, you're helping save your patient's life and their vision. So just remember this right here. And when the time comes up that you have to communicate with the ER physician or hospitalist, you'll be prepared to help them. So remember the E's in GCA, they're E elderly, the ESR is E elevated. They only see the big E on the EI chart, and it is an E emergency. And non-arteritic ischemic neuropathy is diagnosed in the negative. It's diagnosed by what it's not. What is it not? It's not arteritic. How do we know it's not arteritic? Get the tests. Unless it is medically impossible, based upon age, I am always going to get cerebrate, C-reactive protein, and platelets on every case of suspected non-arteritic ischemic neuropathy. We'll always do that. Who does the ultrasound? They have ultrasonographers. Often the ultrasonographers are going to be with a vascular surgeon. And I'm not sure in this office if the vascular surgeon himself does it or he has an ultrasonographer, but it pays to find out who does it in advance to needing it. She's a 66-year-old female, sudden vision loss, new onset vision loss. She's 2400, but she's always been 2400 for a long-standing macular scar. But she noticed an inferior loss of vision of 1 day duration. She has a new onset inferior arteritis. Looking at her, she has disc edema, mild pallor, no hemorrhages, no telangiectasias. It's a small, crowded disc at wrist. The other eye has got less than a 0.2 CD ratio. We talk about her symptoms, mild headache, relieved by some over-the-counter analgesics, a little bit of malaise, a little bit of loss of appetite. She's lost 7 pounds over about 4 weeks, no jaw claudication, no temporal head pain, and she's not a woman in distress. She is a typical Sarasota suburbanite. She's actually in the chair in her tennis outfit. So what do? And you look at it, she's got normal symptoms. You don't want to overreact. She's got that disc at risk. Do I really need to do something about this? Is this? Yes, it is. Her SED rate was 96. And 3 hours after seeing her, she was in a hospital bed with steroids flowing into her arm, and we preserved her good eye. I had an 88-year-old male, not a single symptom to name. Temporal arteritis. It's great. Patient comes in, 72-year-old female who's got throbbing head pain, eye pain, can't get out of a chair, falls asleep, feels poorly for the last 2 months, has intermittent double vision, hurts when she chews. Yeah, that's great. Yeah, my grandmother can diagnose that's temporal arteritis. It's these subtle cases we have to be aware of. And anything at all in this kind of clinical picture is temporal arteritis. So which is better, 1 or 2? This patient went bilaterally blind. This patient had residual field loss, but otherwise not bothered. Here is an important thing to read. Any acute vision loss in the elderly is giant cell until proven otherwise. Also, when in doubt, rule it out. If you ever think, could this be giant cell? You're done. You've got to rule it out. Now, giant cell arteritis, arteritic ischemic neuropathy is a terrible disease. It's a blinding condition. It's one of the worst things we see out there. In terms of optic nerve, it's one of the easiest. It's easy to recognize, easy to diagnose, and the treatment is very straightforward. It's the other neuropathies that are challenging. This is, even though it's a bad disease, it's actually relatively an easy disease. So I'm going to leave you with my ode to an ischemic nerve. When your patient's optic nerve is ischemic, you better hope the disc is hyperemic. In non-arteritic, no treatment is needed.
And your patient's optic nerve is ischemic, bro.
Hold on, I had to mute somebody. And life will rarely be impeded. But if the disc is swollen and pale, and vision is an epic fail, if the patient is 60s, 70s, or 80s, you're going to feel feet like in Hades. ESR and CRP are required, and steroids must be acquired. Remember, when you see a choked disc, always assess the giant cell risk. See if I'm caught up on my chat. Good. 29-year-old female referred to me for a glaucoma evaluation due to suspicious cupping. No complaints. She's 12 and 13, right eye and left eye respectively. I've seen this all the time. Funny looking nerve, very low risk of glaucoma. This patient doesn't have glaucoma. And I was at university at the time. I tell the students, look, show me a normal OCT and let's go on home. So we do an OCT, and the OCT actually comes out a little bit abnormal. Right eye looks good. Left eye's got some nerve fiber layer loss and some ganglion cell loss. But I can tell you right now, this girl does not have glaucoma. All right. Show me a normal visual field so we can go home. So we do a visual field. Right eye perfectly fine. Left eye, a little bit of a nasal step. All right, it's probably just an artifact. Run it again. They run it again. Yeah, it's really there. And it does match the ganglion cell complex and the nerve fiber layer. And okay, now we got to get serious. And actually, we can't go home yet. We actually have to work this patient up and get serious. She's 20/15 in each eye, 12/13 pressure, thin corneas, gonials normal, but she has a marked relative afferent defect, which is a very unusual considering she's got excellent acuity, asymptomatic, and hardly any field loss. And we look at her, we can see she has large cups, and this is the reason that she was actually referred in. Deep cups, large cups, very pink rim in the right eye, but if you notice, she is pale from 12 o'clock until about 3 o'clock. And this is all matching what we've just seen in terms of the visual field and the ganglion cell complex and the nerve fiber layer. She's got this segmental disc pallor. Specifically, she has optic atrophy. And this is a very challenging condition to deal with. There's primary optic atrophy where you have this nerve fiber degeneration. There's glial replacement, but there's really no alteration of the optic nerve head. The disc can be pale, but the margins are pretty distinct and the retinal vessels are normal. And this can be from trauma or compression, such as a tumor. Now, secondary optic atrophy comes from a pathological chronic disc edema, papilledema, pseudotumor, infiltrative disease, leukemia, sarcoidosis, malignant hypertension. Consecutive optic atrophy is a degenerative retinal condition such as RP, pathologic myopia, central retinal artery occlusion. You know, these are pale, waxy nerves, normal margin, with a marked attenuation of the arterial. So the vessels are very important here as well. And temporal disc pallor, if it's bilateral, can be toxic or nutritional. Big one. Always remember that, you know, the hate drugs. H, hydroxychloroquine, A, amiodarone, T, tetracyclines, and E, ethambutol. I've got a patient within the last 2 weeks who was just put on ethambutol for MAC, and I told her I've got to see you every month for OCTs and visual fields because of the potential toxicity. If it's unilateral, it can be demyelinating optic neuropathy. There are so many potential etiologies: infarction, infection, infiltration, inflammation, trauma. Toxicity, metabolic dysfunction, compression, nerve chiasm. So in these patients, we need a pretty good evaluation. MRI of the orbits, optic chiasm, and brain without contrast, fat suppression for the orbits, and a nice high field scanning unit. Contrast gadolinium is going to help identify malignant diseases, demyelinating plaques, indicating multiple sclerosis. But all cases of optic atrophy must be investigated or explained. You can't. If I have temporal pallor and a big macular scar, I'm fine. If I have definitive evidence of past artery occlusion, I'm good. If I see general pallor and extensive panretinal photocoagulation, I'm good. Anything else, we have to do something. Otherwise, you might as well just write on the chart, I think the patient has a brain tumor, but I choose to do nothing about it. Systemic cause, sarcoid, tuberculosis, Behçet's, lymphoma, leukemia, lupus, metabolic disorders, infectious disorders, inflammatory disorders, autoimmune disorders. You know, at this point, I am going to work with a primary care physician. He or she is going to help me, and I'm going to help them. Things that we're going to need: CBC, ESR. I'm getting away from ACE. I don't find to be very helpful. ANA, cardiolipin, homocysteine, B12, folate, RPR. Again, if it's unilateral, I'm not going to be doing heavy metals or folate or B12. If it's bilateral, I certainly will consider that. Chest x-rays can be helpful if you think it might be tuberculosis or sarcoidosis. Now, in this patient, MRI, the orbits and chiasm were normal. Repeat brain MRI, no lesions. I actually worked with the patient's primary care physician at this point. He ordered a lupus panel, ANA, double-stranded DNA, saturate metabolic panel, B12 fold, all normal. RPR, HIV testing, all normal. So I followed the patient for a period of time. Visual field did not change. We did our fiduciary duty, and she was pretty much released. Always remember, you don't always find a cause. Looks like I'm caught up. 54-year-old male referred me for glaucoma management. Told he had glaucoma 6 years earlier in another country, but underwent no treatment. I don't know why. He's 20/30 right eye, hand motion left eye. Comes in, he's got 30 millimeter pressure right eye, 23 millimeters in the left eye. And he looks like this. Fairly large nerves, fairly robust cup of about 7 to 7.5. But what you notice is, comparing right eye to left eye has got a relative degree of diffuse pallor. We don't like pallor. That doesn't happen in glaucoma. Also, 0.7 to 0.8 CD ratio from glaucoma does not match hand motion vision. And the patient does complain of a slowly progressive painless loss of vision. That brings me to polling question number 4. What does this patient most need? Immediate referral to a hospital ER, immediate referral to a neuro-ophthalmologist, a non-emergent MRI of the orbits and chiasm, or nothing, this is just glaucoma. And if you're so inclined to tell me where this photo is taken, put it in the chat box. This will be a little harder. But I'll help you out. It is Canada, and it is the Northwest. So what does this patient most need? Immediate referral to an ER, immediate referral to a neuro-ophthalmologist, non-emergent MRI orbits and chiasm, or nothing, this is just glaucoma. All right, it is Vancouver Island, Victoria, specifically it is Bouchard Gardens. Yep, you got it, Matthew. If you've never been, it's very impressive. All right, so what does this patient most need? All right, we're doing very well, so I'm going to end the poll, share the results. And most people say non-emergent MRI orbits and chiasm. I'm not sure we're going to get an immediate referral to a neuro-ophthalmologist, but a neuro-ophthalmologist, they see your records, will see this patient. And referral to hospital ER, yes, if you're willing to help and tell them what to do or help them find their way to what to do. And these are his visual fields. And I can tell you his OCT was only minimally disturbed in his left eye. His right eye was actually normal. So the OCT imaging didn't really help us in this case. But the clinical picture told us we have a bitemporal defect, very large pituitary macroadenoma impinging on the posterior aspect of the left optic nerve, accounting for the poor vision. And yes, we still need to do fields in the age of RNFL imaging because sometimes it's not just glaucoma. And I will tell you the OCT is actually normal in the right eye and only modestly abnormal in the left. Did not give us a diagnosis. I call this one a family affair. 56-year-old female diagnosed with glaucoma 5 years earlier complains of a slowly progressive loss of vision. Comes in light perception right eye, 20/30 left eye, had been using a combination medicine but ran out several months ago. Pressure is 19 and 18 with average pachymetry. All very possible in terms of the glaucoma diagnosis, all very plausible. When we take a look and what do we see? Fairly large nerves, fairly compromised neuroretinal rim, if we look at it, is a relative degree of pallor in each eye, more so the right eye than the left eye. Now, because the vision was so poor in the right eye, a visual field was not contributory, but in the left eye, we can see a vertically oriented field loss. Exactly the kind of patient that we need to neuroimage. And she had a large pituitary macroadenoma. And the interesting thing about that, I call this a family affair, she was with her sister. And as I was going over the results and discussing the situation, this woman's sister was in the was sitting in a chair in the exam room and overheard our conversation and said, "Yeah, I've got something wrong with my pituitary gland." I said, "What is it?" She was, "I'm not sure." I said, "Is it an adenoma?" She said, "Yeah, I've got a pituitary adenoma." And she said, "I'm using this medicine. I can't remember the name. Is it bromocriptine?" She said, "Yeah, it's bromocriptine." So both sisters had pituitary adenomas. But these last two patients had compressive optic neuropathies. There's compression of the optic nerve in the orbit, the orbital apex, or the chiasm due to a space-occupying orbital lesion, masses, or infiltrative extraocular muscles. The number one cause of compressive neuropathy, optic neuropathy, is not tumor, it is Graves' orbitopathy and thyroid disease. Unilateral in orbital diseases, but can be bilateral or unilateral in Graves' disease. And these patients present with a slowly progressive, painless loss of vision. It may or may not be proptosis, depending on the cause, and there may be a motility restriction. Now, we don't know what happens to the optic nerve initially, but visual fields will be consistent with papilledema and glaucoma in early stages, ischemic neuropathy and glaucoma in later stages. Keep in mind that increased cupping can occur in compressive lesions, but it's concentric. It's not a notch of the neuroretinal rim like we see in glaucoma. It's a concentric enlargement. And also, compression causes pallor. Glaucoma causes notching. So management is going to involve orbital imaging, orbits and chiasm with and without contrast. Attention paid to the paracellular region and fat suppression. And of course, thyroid profiles if Graves' disease is suspected. Now, there's a lot to remember here, so I'm gonna share you my ode to a cupped disc. Ode to have a cupped disc pink, that, my friend, hath a glaucoma stink. But to have a cupped disc pale, call this glaucoma shall fail. Disc and field damage one side, it simply cannot be abided. It might be trauma, infarct, or meningioma, but if the rim is cut, always remember, nothing notches a nerve like glaucoma. And if you can remember that, that'll keep you out of trouble with compressive neuropathies. All right, next patient, 42-year-old female, sudden painless loss of vision, left eye for a week. Getting worse, not getting better. It began as a dimming, then rapidly dropped off. She's 20/20 and 2400 right and left eye, respectively. There is a mild relative afferent defect in the left eye, and that's actually fairly helpful. I'm saying that for a reason. It's very mild compared to the level of vision reduction. Confrontation fields were full peripherally in each eye. She did have a bit of a central scotoma in the left eye. Slit lamp was normal. Pressures were normal, but fundoscopic evaluation was definitely abnormal. Now, in her fellow eye, she's perfectly normal. But we have a massively edematous optic nerve, juxtapapillary edema, juxtapapillary exudation, and we have this pointing of exudates in Henle's layer going from the disc to the macula in what is known as a partial macular star. Now, she's got no known HIV risk, recent illness, a bad flu. This is before COVID, with malaise, fevers, lymphadenopathy about a month earlier. No tick bites, no rashes, not Lyme, not necessarily in the Lyme endemic area, but she does have exposure to cats. Serology, FTA-BS, RPR for syphilis, HIV testing, Lyme testing, toxoplasmosis testing, toxocariasis testing, PPD for tuberculosis, all negative, but she does come back with high titers of Bartonella Hensley. Thus, she was diagnosed with cat scratch neuroretinitis. But more specifically or broadly, she has infectious optic neuropathy. This is a very, very broad topic. Neuroretinitis and cat scratch disease is just a subset of this monstrous topic. There are a number of things that can do this. Syphilis can give you a retrobulbar neuropathy, a bulbar neuropathy, a neuroretinitis, that can be syphilitic, and a perineuritis. Perineuritis is inflammation and swelling of the optic nerve sheath, but the optic nerve is relatively preserved. Thus, these are patients who have disc edema, but generally very good visual acuity. Now, these patients with syphilitic neuropathies, severe vision reduction if it's bulbar or retrobulbar, but the perineuritis has normal vision, and the MRI will show optic nerve sheath enhancement. So swollen optic nerve with good vision is actually pretty suggestive of perineuritis, and perineuritis is pretty suggestive of syphilis. Now, Lyme disease can do the same thing syphilis does. Both are spirochetal bacteria. Lyme mimics syphilitic optic neuropathy. So everything I said for syphilis, I say again for Lyme. The difference is one is Borrelia burgdorferi, the other is Treponema pallidum. They're both spirochetal bacteria. Syphilis obviously is a sexually transmitted disease. Lyme disease is transmitted by the bite of the deer tick. People who are in the woods, who are camping, hunting, people around large mammals, deers, other boars, these are people that can pick up Lyme disease. In fact, people can test positive for each. People who are syphilitic can test positive for Lyme and vice versa. Toxoplasmosis, HIV, AIDS, that's all very destructive division. Neuroretinitis is really usually a benign lymphoreticulosis or a cat scratch disease. So neuroretinitis, the key is a mild pupil defect compared to severity of the vision loss, telling us that the dysfunction is more retinal than optic nerve. The macular star that I showed you here is a relatively late 2 weeks plus finding. Initially, they can look like this. You see, there's no macular star there. That's a late finding. However, very diagnostic is a serous macular detachment from the disc to the macula. So use the OCT when you see these patients. Not edema, it's not macular edema, not macular soil, not CME, a serous macular detachment going from the disc to the macula. If you can see that, you're dealing with neuroretinitis, you're dealing with infectious optic neuropathy. We just have to figure out what the cause is. And here's a nice example, a patient, 62-year-old who was diagnosed with quote unquote strep throat, count fingers at 8 feet, on antibiotics for 1 day already, has a relative afferent pupillary defect, but very mild for count fingers vision, black spot and blurry vision for 3 days. We can see the nerve is swollen. There is no macular star, but there is a serous detachment. So the OCT is very helpful. And this tells us we're dealing with neuroretinitis or a manifestation of infectious optic neuropathy. So neuroretinitis and infectious optic neuropathy, many potential etiologies. Toxoplasmosis, toxocariasis, measles, syphilis, Lyme, herpes, zoster and syphilis, mumps, tuberculosis, middling hypertension, ischemic neuropathy, leptospirosis, Bartonella. Bartonella is really the most common cause of neuroretinitis. And fleas are the vectors, not the scratch, but the flea bites. And you can see this is why I actually prefer working with a primary care physician when dealing with these patients. Prognosis for recovery is excellent, especially if it's cat scratch disease, Bartonella hensley or Bartonella quintana. Most patients will have a normal or near normal return to vision without treatment. Now, antimicrobial therapy can be used to speed things up, but things that have been tried, rifampin, ciprofloxacin, doxycycline, sulfamethoxazole, doxycycline again, 100 milligrams by mouth twice a day for a month. You know, because the macula is mucky and wet, I mean, people have injected Avastin. There is no study that shows Avastin or antimicrobial therapy is going to help. If you want to do something and you want the patient to feel you're doing something, and you want to prescribe an antibiotic, a course of oral antibiotics, have at it. This is what the diagnosis is. You're sure of the diagnosis. Give whatever you like to use. Keflex, great. Doxycycline, great. I wouldn't use ciprofloxacin or anything else that could have some side effect. Whatever you like, azithromycin, have at it. They'll feel a lot better. Now, if it isn't cat scratch disease, we've got to find out potential cause and treat that. Be it syphilitic disease, Lyme disease, herpetic disease. So keep in mind, neuroretinitis is just a subset of infectious optic neuropathy. We do have to work, when we suspect infection, we have to do a very thorough evaluation. And I will work with a PCP or infectious disease specialist. They know their roles, I know my role, and we work together. So I'm going to help you out with my ode to an infected nerve. When the vision is poor and the APD mild, it's often the bite of something wild. If the disc is swollen and macular swelling great, it's neuroretinitis and the start will come late. Syphilis and Lyme are much alike and cause similar titers to spike. One is sexually transmitted and the other not, unless the patient's weirder than you thought. If you can remember that, that's all you need. Looks like I'm caught up in the chat. So let's move on. We're going to finish nicely on time here. A couple challenging cases. 48-year-old female presents with sudden loss of vision in the right eye, 2 days duration. Had gone to an ER where her CT of her head was normal. By the way, anything involving vision, double vision, vision loss, the eye, anything like that, they go to an ER, they will get a non-contrast enhanced CT of the head. They want to rule out hemorrhagic stroke, and that's it. That's what they all do. Thank you, Richard. Okay, so she went to her primary care physician who diagnosed her with zoster, prescribed Valtrex and prednisone, but she had not used either of these yet because she didn't think she had zoster. And she is referred to me to examine her and rule out any ophthalmic manifestations. So when she comes in to see me, she's 20/60 in the right eye, 20/20 in the left, and she has a relative afferent defect. And this is not your normal case of shingles. Color vision was 14 out of 14 right and left eye, but she struggled mightily with the right eye. And she's complaining of retroorbital and temporal pain, which is why she was diagnosed with zoster, even though she had no vesicular eruptions. And we take a look at this, and what do we see? Okay, relatively small nerves, modest cup. Left eye has non-specific defects. We have a pretty significant inferior arcuate defect developing in the right eye, and the optic nerve looks perfectly normal. So we have this 48-year-old female who's got a pain retroorbitally, pain in her head. And then brings me to polling question number 5. I'm not going to ask you more about this. You know who that is. Hold on. Let me launch my poll. So what testing should be done for this woman? Does she need an MRV, an MRA, and a MRI of the brain with and without contrast, MRI of the orbits with and without contrast? What does she need? So going back, 48 years old, she's got a normal head CT diagnosed with zoster, prescribed Valtrex and prednisone, using neither. 20/60 with an afferent defect, some dyschromatopsia, retroorbital and temporal head pain, especially when she moves her eye, a normal looking optic nerve, an inferior arcuate defect. And we know that's Mick Jagger. That was the Miami Arena. Got close enough to actually see that list. So people responding, doing well. What testing does she need? MRV, MRA, MRI brain with and without contrast, MRI orbits and chiasm with and without contrast. Got a lot of people coming in, almost done. All right. I guess for the sake of experience, I'm going to end the poll, share the results. Okay, so what are we looking for with an MRV and an MRA? We're looking for things that are abnormal in the venous system or the arterial system. But this is a patient we have to consider may have demyelinating disease, and she's actually going to need really urgently both MRI of the orbits and chiasm with and without contrast, as well as MRI brain with and without contrast, and those are 2 separate studies. Oh, that brings me to number 6. What's the most likely diagnosis? Optic nerve infection, infiltrative neuropathy, compressive neuropathy, demyelinating neuropathy. I don't know. Zoster seems pretty good to me. Yeah, if you're so inclined, where is this picture taken? Put it in the chat room. Should be easy one. Arizona, correct. Specifically, it is the Grand Canyon. So what are we dealing with here? Infection, infiltration, compression, demyelination, or I don't know, zoster seems pretty good. All right, I'm going to end the poll, share the results. And most people think she has a demyelinating optic neuropathy, and I think that's pretty reasonable. So MRI of the orbits and brain. We had some enhancing lesions suspicious for optic neuritis. Punctate confluent foci of abnormal prolongations predominantly, raise the possibility of demyelinization with optic neuritis, and that's what she had. She had demyelinating optic neuropathy and or a precursor to multiple sclerosis. This is a focal inflammatory demyelinating event. The optic nerve can be idiopathic, involving only the optic nerve, or associated with other systemic illnesses such as multiple sclerosis. About a third present a swollen optic nerve, 2/3 are retrobulbar with an abrupt vision loss. About 20/60 is on the average. It can get much worse. There's typically a relative afferent defect with dyschromatopsia, decreased brightness and contrast sensitivity, and usually progresses over about a 2-week period with a gradual recovery of about 12 to 18 months with or without treatment, but there may be some deficits remaining, particularly with contrast sensitivity. In the optic neuritis treatment trial, not 92% of these patients had pain. So usually orbital pain, retroorbital pain, in my experience has been, in these patients, the premonitory symptom, pain and eye movement, dyschromatopsia, the vision loss usually comes number 3. Because when the pain and the dyschromatopsia occur, the severity of the acuity loss really hasn't hit its nadir just yet. MRI is going to be critical in diagnosis and management. The optic neuritis treatment trial 15-year results. Conversion to clinically definite multiple sclerosis was 50% overall. Now, if they had a normal MRI at baseline, there's only a 25% conversion to clinically definite multiple sclerosis. But if they had an abnormal MRI at baseline, which is what we have here, there's a 75% conversion. The lowest risk of conversion to clinically definite multiple sclerosis in the optic neuritis treatment trial were males, those with disc swelling, papillitis. They had no pain, and they were no light perception. Now, in reality, the majority of these patients were probably misdiagnosed. They probably had a different disease, but were put into the ONTT erroneously. So male, swollen nerve, no pain, no light perception, that doesn't really follow your typical demyelinating optic neuropathy. I don't know how well I believe all of this. But a normal MRI baseline and no clinically definite multiple sclerosis at 10 years, then they only have a 2% risk of developing MS at 15 years. Now, when I was in my training, we had a don't ask, don't tell approach. We didn't want to diagnose optic neuritis because we had nothing that we could do to treat it. So we did everything but make that diagnosis, because once we put optic neuritis on that young woman's chart, it would now be difficult for her to get health insurance, medical insurance, life insurance. And we just didn't, we took a don't ask, don't tell approach. Nowadays, we want to rush to diagnosis. We want to make the diagnosis as efficiently as we can and get them in the hands of a neurologist specifically skilled in demyelinating disease, because now we have interferon therapies like beta-serone, Capaxone, Avonex, which can really slow the accumulation of disabilities. So there really is there's a penalty for not starting immunomodulatory therapy as early as possible. So we've gone from a don't ask, don't tell, because we can't do anything, you couldn't do anything about it, now to efficiently get the diagnosis made, because there are things that we can do to slow disability. These people need to be diagnosed and in the hands of a neurologist skilled in multiple sclerosis. So now I'm going to share with you a tale of 2 optic nerves. Optic nerve number 1, 72-year-old woman noticed a darkness right eye of unknown duration. Medical history, asthma, hyperlipidemia, psoriasis, history of herpes, using Flonase, Valtrex, Otezla. She's 20/25 right eye, 20/20 left eye, has a relative afferent pupillary defect in the right eye. and she looks like this. Her OCT looks pretty well normal. Her left eye looks pretty well normal visual field. Right eye, we have an inferior arcuate defect. This is the darkness that she notices in her visual field. And we have some pretty profound, we make a comparison, disc pallor. So notice the darkness, unknown duration, not an especially helpful medical history. 2025, 2020, there's a marked APD, disc pallor, inferior arcuate defect. What next? Put it. It's not a poll. Put it in the chat. What do you do next? Have you ever seen this before? The patient comes in who's got optic atrophy, who's got vision loss, without a heck of a lot of information or a lot of help to find out what's going on. Think about it, and I'll let you have a minute and put it in the chat. Anybody? Somebody out there? All right. So it looks like this: pale nerve, field defect, afferent defect. Some people are thinking about it. What is in the chat? OCT. OCT is normal. At least the macular OCT is normal. Hunt the ophthalmology. Jennifer, I can tell you, the ophthalmologist in my practice don't want this. They punt back to me. They kick the can back down to me. Needs MRI of orbits and chiasm. Old NAIN just recently noticed, not bad. You know, certainly could be a disc at risk, not bad at all. So Rich, I'm gonna give you some kudos on that. All right. Well, here's optic nerve number 2. 72-year-old woman, new onset flashing lights. She thinks it's in her right eye, but flashing lights, she can't tell if it's right eye or both eyes. No floater. She's 20/20 each eye. Pupils are normal. No afferent defect. Confrontation fields are full. She has a multifocal IOL, asthma, hyperlipidemia on Valtrex, and this is what she looks like. Very, very swollen, acute optic nerve. Is this acute? Absolutely. That's not chronic. Hint: she has been to a Lyme endemic area recently. Here's her OCT, and here's her visual field. So, good vision, no afferent defect, full fields, swollen nerve. She's been to a Lyme endemic area. Brings me to polling question number 7. I think it's my last one. Okay, go back. Stop sharing. Now I can get this up. Poll question number 7. What's the most likely diagnosis? Compressive tumor, infectious optic neuropathy, ischemic optic neuropathy, GCA, infiltrative optic neuropathy, CRVO variant, or I don't know. That's why I'm here. And if you're inclined, where is this photo taken? You see EOG, SED rate CRP, stat, Lyme titer, Western blot. Good, Richard. I like what you're thinking. So where's this photo? If you can tell. Seattle close. I call it Seattle's sister city on the other side of the globe. They have their own needle and everything. It is. Anybody? Here, Toronto. Good thought. Nope. It is Auckland, New Zealand. All right, we're doing great here. Finishing up our poll. Share the results. Most people think it's infectious optic neuropathy. Some people think that it's kind of spread out. And I'm not going to kid you, optic nerve is hard, guys. I'm dealing with the one from last week, brand new neuropathy. Still not sure where we're going with it. Optic nerve can be tough, so don't think that it isn't. All right, presumptive diagnosis. Can't be CL, no coffee stains. That's a good one. Presumptive diagnosis: infection, optic perineuritis, swollen nerve, good vision. MRI brain and orbits and chiasm with contrast and without contrast and with fat suppression. I know what this is. All right, Lyme disease, Lyme infectious area, perineuritis. Unfortunately, the imaging is normal. I hate it when the diagnostic imaging doesn't agree with my diagnosis. So I called the neuroradiologist and asked him, please reread it and specifically look for the optic nerve sheath. Is there any enlargement and is this perineuritis? It's got to be Lyme disease. Said, nope, sorry, just isn't. Everything looks normal. Now on to serology, working with a PCP. And, he was glad to have the help. He said, yeah, there's something that begins with a T, right? I said, yeah, toxoplasmosis. So everything, CBC, SED, CRP, ANA, RPR, FT, ABS, ACE, zoster, rubella, toxo, Lyme, Bartonella, Hensley, Quintana, all normal. The only abnormalities were herpes simplex and some Epstein-Barr, all indicative of old issues. So non-contributory. So imaging normal, serology normal, everything normal. No conclusive diagnosis. Now, the rub here, so that you know, it's the same patient. Tail 2 optic nerves this is how she started out. She was 2020. We worked through her and worked everything up. We found nothing. This is how she ended up. So whenever you see a patient like this, you wonder, where can they end up? This is where they can end up. Or if you see a patient like this, how did this happen? Where did this come from? Maybe it came from something like this. And she was virtually asymptomatic. She had flashes. She went to one of my colleagues who dilated, thinking she might have a retinal detachment, and saw this and referred the patient to me. So this is the same patient. About 4 months later, her fellow eye is fine. She's living a good life. We found no cause. So my disclosure here, I probably should have given you this at the very beginning. Optic nerve diseases often don't end well. It's a relatively delicate structure. The answer, Richard, no uveitis. And I think we're at about our time. We got a couple little cases, not worth anything, not worth going further here. I'm just going to wrap up something real quick. This is a patient that I saw last week. I'm still working the patient up. 74-year-old male, 5-day history of a line across his right eye, superior artery defect, 2060, trace APD, no evidence of giant cell arteritis, has maintained this vision. We're getting the imaging and serology right now. So maybe next time we meet, I'll have an answer for you here. So let's just wrap this up, because I know that we are at the end, and that is the end of my presentation. It's got a little bit of housekeeping for everybody. So our synchronous virtual